Hello, everyone, and welcome to our ECHO session today. Our sharing sessions are made possible given the generous support from the Bill and Melinda Gates Foundation to the LabCoP project implemented by the African Society for Laboratory Medicine and partners. Today, we'll focus on improving the quality of diagnostics for drug-resistant tuberculosis. And of course, our housekeeping rules remain. The session will run for 1 hour. We'll take 2.5 presentations and get to some discussions. Kindly join the discussions through the chat. We do have real-time language interpretation services, and so keep to either English, French, or the Portuguese channels and stay away from the off channel. My name is Francis Ochen from the African Society for Laboratory Medicine, and I'm delighted to be your moderator today. And like I've already indicated, we focus on improving diagnostics for drug-resistant TB today. We are aware that tuberculosis, and more so drug-resistant tuberculosis, remains a significant public health concern, given the increasing resistance to some of the foundation drugs that we know, rifampicin, isoniazid. But also as well, we have resistance that are now developing to the alternative second-line fluoroquinolones, and that's not very good news. It is therefore imperative that most cases of drug-susceptible TB and drug-resistant TB are diagnosed in time and treatment initiated early. And so in today's session, we'll focus on Cepheid's Expert MTB and XDR technology, looking at what it is briefly, and then some of the results from the verification studies that have been done in Uganda, and then we'll look at some early implementation experiences from Mozambique. And to take us through this, we have 3 presenters. Our first presenter from Cepheid is Dipti Lalobai, and Dipti is a senior manager with medical affairs at Cepheid. And then the second presenter will be Dr. Willie Sengoba, and Willie is an infectious diseases expert working with Makerere University College of Health Sciences in Kampala, Uganda. And then the last presenter is going to be Dr. Claudia Cardoso, and Claudia is the national focal point for multi-resistant tuberculosis with the National Program for Tuberculosis Control, the National Directorate of Public Health at the Ministry of Health in Mozambique. So colleagues, allow me to hand it over to our first presenter, and we'll then do the questions and answers after all the 3 presentations are done. Like I indicated, your only chance to participate is through the chat. So please keep your questions and comments coming through the chat, and we'll deal with them through, during the questions and answer session. Dipti, let me hand it over to you.
Thank you, Francis. And thank you to ASLM for allowing us to present today. Okay. So thank you, everyone. And I think the goal for today is really where can we work towards closing the gap and improving diagnostics for drug-resistant TB. For the sake of bandwidth, I'm just going to put myself on stop the video, if that's okay. I'll pick it up again when we have a question and answer session. Ultimately, where are we at right now? In terms of the latest global report from 2023, molecular, WHO recommended molecular diagnostics used for initial diagnostics was only 47% of the 7.5 million people that were newly diagnosed with TB in 2022. This is slightly increased from 38% in 2021 and 33% in 2020. Of course, there are actions that we need to mitigate and reverse the impacts that have resulted from COVID, and these are required. These are urgently required. The immediate priority is, of course, to restore and to reassess and provide essential TB services at such levels that the TB case detections and TB treatment can recover to at least the 2019 levels, especially in the most badly affected countries. if we look at the estimated number of people who have developed MDR TB and RIF-resistant TB in 2022 for countries with at least 1,000 incident cases, there are 3 countries that accounted for 42% of the estimated global number of people who have developed multidrug-resistant and RIF-resistant TB in 2022. With India at 27%, with the Philippines at 7.5%, and Russia, the Russian Federation at 7.5%. Of course, not forgetting the African continent, where the numbers are extremely, also, in the realm of 1,000 to 10,000 in certain countries. So where are we at with access to TB diagnostics? 62% of people have had no access to rapid molecular diagnostics for TB. More than 4 million people are undiagnosed, untreated, and potentially transmit the disease in the community. There are more than 400,000 people that are infected with drug-resistant TB. This is multi-drug-resistant as well as RIF-resistant TB. And there's only a 63% treatment success rate for people who have started second-line treatment. When we look at the WHO guidelines and the consolidated guidelines with the operational handbook, they do indicate that expert MTB XDR may be used for sputum, for using sputum on initial detection of RIF-resistant resistance to INH fluoroquinolone rather than using the culture-based phenotypic DST. They also indicate that for any RIF-resistant case, sputum for initial detection of resistance to ethionamide is recommended rather than DNA sequencing of the INH promoter. In addition to that, they also recommend that resistance to rifampicin, the use of the expert MTB XDR assay may be used for initial detection of resistance to amikacin rather than culture-based phenotypic DST. It is also recommended that the MTB expert XDR assay is a low complexity automated NAAT test for the detection of resistance to isoniazid and second-line anti-TB drugs. What has also happened over time is that the recent classification of the different technologies for NAAT testing has been aligned to low, moderate, and high complexity tests. And expert is the only one that is aligned to the low complexity NAAT test that is currently available for effective drug-resistant TB testing. So what is the Cepheid solution? When we look into the detail and the evolution of TB diagnostics, the original test being the MTB RIF assay, followed on in 2017 by the MTB RIF Ultra assay with improved exceptional clinical performance with a result in less than 80 minutes. And now we have, of course, the latest with a product that is there to aid in the diagnosis of multi-drug-resistant TB with a result that you are able to achieve in less than 90 minutes. The intended use of the expert MTB XDR assay is performed basically on the GeneXpert system, and it's a qualitative nested real-time PCR in vitro diagnostic test for the detection of extensively drug-resistant TB, Mycobacterium tuberculosis complex. It is also used in specimens where MTB is detected. The expert MTB XDR test can also be detected, for INH and its associated mutations in CATG, FABG1 genes, the OxyR AHPC intergenic region, and the INHA promoter. For ethionamide, resistance associated with INHA promoter mutations are detected, and for fluoroquinolones, resistance associated with mutations in the gyro-A, gyro-B, quinolone resistance determining region. And second-line injectable drugs are associated with mutations that are noted in the RRS and the RRS gene and the EIS promoted region. Of course, this is considered to be intended for a reflex test for a specimen using unprocessed sputum, concentrated sputum sediments, or midget culture that is determined to be positive for MTB. The pathway that can be considered for accurate diagnosis and, of course, enable timeliest same-day treatment initiation is reflexing the expert MTB ultra assay for any MTB detected risk susceptible test to the expert MTB XDR, as well as an MTB detected risk resistant outcome on the ultra assay to the expert MTB XDR assay. And of course, this is to enable and initiate an optimized treatment as per the country guidelines. It can also be used in terms of, when we're looking at culture to confirm within 4 to 6 weeks that the test can be used for culture as well. And this will enable adjustments to drug treatment as needed. Following on to that, there were 2 studies that were conducted when we registered this product. So there was a blinded clinical study that was conducted to evaluate the performance of MTB XDR relative to the microbiological and molecular reference methods. And this was done in 2 countries with high prevalence of MDR and XDR TB, where they provided frozen archived sputum as unprocessed sputum, as well as concentrated sputum sediments that were also known to be positive or negative by TB culture. Ultimately, when we look at the sensitivity and the specificity of these relative to phenotypic DST, the sensitivity was greater than 90% for INH, fluoroquinolone, and amikacin, greater than 85% for kanamycin, capreomycin, and slightly less in terms of just over 64% for ethionamide. The specificity was greater than 98% for all drugs. When we look at this data versus the relative to sequencing, the sensitivity was greater than 93% for fluoroquinolones and greater than 96% for INH, amikacin, kanamycin, capreomycin, and ethionamide. The specificity was 100% for all drugs, with the exception of INH, that was 98.7%. As you can see, sequencing as a reference was used for, and the same targets were assessed during this evaluation. There was also a prospective assessment done, and this was in close collaboration with FIND, and it was done in 3 different countries, basically India, South Africa, and Moldova. The sensitivities, these are the sensitivities depicted in our package insert that also align with phenotypic DST, with a sensitivity of greater than 90% for INH, fluoroquinolone, kanamycin, greater than 85% for amikacin, greater than 70% for capreomycin, and greater than 50% for ethionamide. The specificity was greater than 92% for all drugs. When we look at sensitivity relative to sequencing, the sensitivity was greater than 90% for INH, fluoroquinolone, and kanamycin, greater than 70% for amikacin, greater than 65% for capreomycin, and greater than 95% for ethionamide. The specificity again was greater than 98% for all drugs. Here again, we can see sequencing as a reference method, as a reference standard used for the same targets as well. And ultimately, the clinical performance in sputum samples is comparable across the different geographies in the retrospective as well as the prospective data sets that we've just looked at. Finally, the outcome, this analytical performance highlights really the expert MTB XDR assay that demonstrated equivalent limit of detection to the expert MTB RIF assay. It also detected 100% in terms of the resistance mutations tested, and showed some utility for the resistance detection in strain mixtures. For heteroresistance assessment, there was 100% detection of resistance when resistance populations comprised of 10% of the mixture for INH, 25% of the mixture for fluoroquinolone resistance, 50% for ethionamide, amikacin, kanamycin, and 60% for capreomycin. The expert MTB XDR assay reliably also detects wide range of globally relevant isoniazid, ethionamide, fluoroquinolone, and second-line injectable resistant mutations. And finally, the expert MTB XDR assay is reliable, sensitive for tuberculosis, and expanded resistance detection. I'd like to say thank you and hand it over to the next speaker.
Thank you. Thank you very much, Dipti, and a very good and comprehensive summary of the global TB burden that really justifies the need for having some of these tools available. Colleagues, I will take the next presentation right away. And please keep your questions coming through the chat and we'll deal with them at the end of the session. So at this point, let me invite Willie Sengoba, Dr. Willie Sengoba from Makerere University, to take us through some of the verification study results that they've done here in Uganda. Willie, over to you.
And thank you, Francis, and thank you, ASLM, for this opportunity to share our findings of the validation exercise that we did for the expert XDR for the detection of first-line and second-line drug resistance, but also the status of uptake and rollout in Uganda. This is the presentation outline that I'll take you a brief background, rationale, main and specific objectives of the study, what we found out, some highlights of the discussion, conclusion, and way forward, as well as the status of rollout in Uganda. As we know very well, TB remains an important cause of global morbidity and mortality, and drug-resistant TB remains a major challenge for TB control. And still, much as there is quite a number of innovations in treatment, drug-resistant TB treatment remains longer and more expensive, coupled with several aspects of side effects and other aspects that impact treatment outcome. But it remains a huge gap in the diagnosis as well as treatment initiation that we think that new diagnostics could help to reduce. There is an urgent need for rapid and accurate drug accessibility testing method for the core drugs in the first line and second line regimens. And there are several technical and operational challenges with the existing drug accessibility methods that need to be addressed with the newer and more rapid friendly DST methods. Effective management of drug susceptible and drug resistant TB, we know very well that it relies upon early diagnosis, and this includes universal drug accessibility, access to drug accessibility testing, as well as effective treatment of the resistant TB strains. And there is higher benefits for fast, preferably molecular diagnostic test for drug susceptibility testing, which leads to fast initiation of appropriate treatment. So the tool that is being mentioned, the Expert XDR, looks like this. We normally call it Blue Label. We have them at our sites, the 4 module, we have the 16 module, and these have been deployed in the treatment centers, you can see. We can see the advantages of this tool, benchmarking on the Expert Ultra, which detects resistance to rifampicin, and those patients who are resistant to rifampicin can be reflexed to MTB, Expert MTB XDR, to rule out resistance to isoniazid and fluoroquinolone, and then they can be initiated to optimize the treatment. But even those that do not turn out to be Expert positive but culture positive, we can have Expert XDR, as Deepta has shown, on cultures, at least to get timely drug susceptibility profile for effective management. But also in countries where we anticipate that we can have high resistance to monoresistance to isoniazid, it has always been a recommended test to do that. So this test, after its endorsement in 2021, we set up to validate the performance of Expert XDR test for susceptibility testing of Mycobacterium tuberculosis among presumptive XDR patients. And the test performance indicators were compared with the current drug susceptibility methods, including MIGIT and line probe assay. We assessed specifically the sensitivity and specificity of the Expert XDR test in previously stored sputum samples, compared to phenotypic DST method, and we repeated the same as compared for genotypic DST method, that is the Hain line probe assay for first line and the second line drug resistance testing as the gold standard. The second objective was to evaluate the feasibility for uptake and the factors that can influence uptake, rotating around training needs, recording and reporting needs, the error rates, and the proportion of results that are interpretable. We looked at the turnaround time as well as the workflow that is needed to go through this. The study design was a blinded laboratory-based cross-sectional study to determine the performance of the Expert XDR using stored samples. And we used the patients' samples also, which were MTB positive, as well as culture isolates, where the sample did not had no drug safety testing. So we got the culture isolates and repeated the phenotypic DST and compared this with the Expert XDR, looking critically on the isoniazid and the second line fluoroquinolones, which are the remaining relevant drugs in the tuberculosis management of drug-resistant TB. The study was approved by the Uganda National Council of Science and Technology and was conducted between 2021 and 2022 April. So what were our findings? We found out that the test performed very well. Looking at isoniazid, we got a sensitivity of 89% and specificity of 88%. And this is comparing with the phenotypic DST as a reference comparator. Looking at fluoroquinolone, we got a sensitivity of 80% and specificity of 100%. We had no resistant strains, given that Uganda is a low MDR setting, but also in the panels that we used, we had no resistant strains to injectable agents. So, but we recorded all of the isolate, all the samples to be negative, and therefore the specificity of 100%. When we used line probe assay, first line and second line as a reference comparator, the Expert XDR achieved a sensitivity of 96% and specificity slightly reduced to 74%. For fluoroquinolone, the sensitivity came to 100% and 99% specificity. And we remained with the same record with the injectable agents. So we gave the checklist that were adopted from the FIND studies that we normally do, looking at the training need, recording and reporting need, and error rates. We found that people who had previous experience with the expert, they needed to be oriented to this test within 1 day. They needed no experience actually, those ones who had previous experience with the expert XDR, but those without experience with the expert XDR, and actually we got the technicians who are doing line probe assay, who are doing other molecular tests, they were able to get this test and be able to run the test with good results within 1 day. The recording and reporting needs were not different from those required when you're doing the expert ultra. We recorded an error rate of 4%, which was for us acceptable, and we had no uninterpretable results. The turnaround time remained 1 hour 45 minutes, and the workflow was similar to that of the expert ultra. So in this study, we recorded the high sensitivity and specificity of the expert XDR cartridge for isoniazid fluoroquinolone and the specificity for injectable agent. We saw that better diagnostic accuracy was seen when compared with the line probe assay as a reference standard. And this is in line with the literature because they are both genotypic methods. We have recorded better test attributes in terms of training needs, turnaround time, error rates, as well as the workflow. And these differences that we have recorded between phenotypic and genotypic DST are well documented because of the different targets that these two methods look for. So in conclusion, and go forward, expert XDR test is a reliable and rapid, accurate, and easy to use DST method for isoniazid, fluoroquinolone, and injectable agents. And the countries should consider that all new expert machines procured should be 10 color for easy integration. And the drug treatment centers should be prioritized to have 10 color machines. And we felt that manufacturers should plan to swap the 6 color with the 10 color to ensure better access to XDR test in all expert sites. And all of these, apart from the last one, our country has embraced this because we did the validation to inform rollout, which I must say that currently we do research studies, which are network studies. They have accepted validation results, and they have switched to expert XDR for patient screening in the clinical trials. And Uganda has considered uptake and rollout of expert XDR and revised the diagnostic algorithm. All drug treatment centers now have 10 color machines, and all rifampicin-resistant TB patients are tested for isoniazid fluoroquinolone using the expert XDR. And currently we have 22 drug-resistant treatment initiation sites, and all of them, they have a 10 color machine, and we plan to increase this as we decentralize DRTB management. As you can see below here, the arrow shows that within this elaborate diagnostic algorithm, we do have the expert XDR assay captured here and also captured here within this algorithm that I may not go much into details in the interest of time. So that, but this is a proof that uptake is already and rollout appreciated in Uganda. I've presented this work on behalf of the co-authors, and this work has been already published in 2023. And thank you very much.
Thank you. Thank you very much, Dr. Willie Sengoba. A very comprehensive presentation, quite clear an approach to doing verification validation studies. And we can quickly then see that it gets taken up because everyone believes in the results that come out from very clearly designed and implemented validation studies like this one. So again, colleagues, keep the questions coming. And I know that my colleagues from Cepheid and now Willie will also be getting to the charts to be dealing with some of the questions that are already there. Now, let me hand it over to Dr. Claudia. And again, just to let everyone know that you should be in one of the channels that suits you, either English, French, or Portuguese, because Claudia is going to be presenting in Portuguese. Claudia, over to you. Thank you very much.
Boa tarde a todos. Então, eu vou fazer a apresentação da experiência de Moçambique no uso do Expert XDR. Ok. Então, se nós conseguimos ver aqui, nós temos uma notificação, taxa de notificação de tuberculose de 361 por 100 mil habitantes, enquanto que a nível global temos uma média de 133 por 100 mil habitantes. Isto são dados do relatório de 2023 da OMS. Moçambique tem melhorado a sua testagem no uso desses tipos de testes moleculares para o diagnóstico da tuberculose. Como podem ver, nós estamos entre 60% a 79% de testagem. Quando olhamos para a situação de Moçambique, Moçambique faz parte desta lista, lista dos países com alta carga de tuberculose resistente e tuberculose HIV. A nossa taxa de coinfecção tuberculose HIV é relativamente alta, embora já esteja a reduzir, estamos com 25%. Tivemos em 2022, lembrando que este é o relatório de 2023 da OMS, tivemos em 2022 cerca de 1.440 casos de tuberculose multiresistente, temos uma taxa de casos de TB pediátrico em tuberculose de todas as formas de 12%. Ainda temos desafios na confirmação bacteriológica. Naquele ano tivemos cerca de 43% dos casos eram confirmados laboratorialmente. Olhamos para a cobertura de tratamento, ela tem vindo a aumentar. Ainda assim, a taxa de sucesso de tratamento para a tuberculose resistente continua com 75%. Olhando para a nossa estrutura laboratorial, nós temos 4 níveis de atenção. Temos os centros de saúde no nível mais baixo, onde podemos encontrar essas tecnologias, desde microscopia, LED e Ziel-Nielsen em alguns locais. Temos equipamentos de GeneXpert de 6 cores, alguns equipamentos da Molbio e também algumas unidades sanitárias é possível fazer o TB-LAM. No nível mais alto temos diversos tipos de tecnologia, entre elas para a cultura, para o LPA, assim como para o sequenciamento genômico. Como podem ver aí na tabela ao lado, nós temos a distribuição destes tipos de tecnologia, tudo que existe no país neste momento. O nosso algoritmo de testagem, deixa-me só encontrar aqui um ponteiro. No nosso algoritmo de testagem, nós, como a maior parte dos países, nós não temos GeneXpert, nem outra tecnologia molecular em maior parte dos lugares. Então, para todas as unidades sanitárias que não têm nenhum tipo de tecnologia molecular, devem fazer primeiro a baciloscopia, a microscopia, e depois enviam uma amostra para unidades sanitárias que tenham o GeneXpert. Como mostrei no slide anterior, a maior parte das unidades sanitárias tem um expert de 6 cores, desculpa. Então, eles fazem o expert, ou seja, o expert ultra, e nós escolhemos, independentemente de ter casos, devem enviar aqueles que forem detectados para fazer o expert 10 cores. Nós tomamos esta decisão porque, no caso de Moçambique, nós temos uma prevalência de resistência à isoniazida um bocadinho alta. No nosso último estudo, que ainda estamos por publicar, temos dados acima de 5% para a resistência à isoniazida, além de outras dificuldades para envio de amostras para os laboratórios centrais de referência. Então, todos aqueles que forem MTB detectados, independentemente do padrão de resistência, ou seja, que seja sensível ou resistente, neste caso, nós iniciamos o tratamento de acordo, mas temos que mandar amostras para o Expert XTR. O objetivo de enviar estas amostras o mais cedo possível é para ter os resultados para uma melhor decisão clínica. Nós pretendemos que, pelo menos em 2 ou 3 semanas, no máximo, nós tenhamos informação de resistência à rifampicina e informação de resistência à isoniazida e às quinolonas, com o objetivo de fazer o melhor tratamento logo no início. Porque uma das coisas que nós fomos observando na nossa prática clínica é que nós tínhamos pacientes que, por exemplo, tivessem tuberculose sensível e nós descobríamos no final do tratamento, quando faziam falência, que afinal de contas tinham resistência à isoniazida. É verdade que o número de casos não era muito alto, mas sabemos que quanto maior for o padrão de resistência, pior é o prognóstico do paciente. Este slide acho que é parecido com o do colega que esteve a apresentar há pouco, é só em relação às condutas clínicas que devem ser feitas para cada um dos casos. Quando olhamos para a evolução da testagem, nós temos estes números. No ano 2023, tivemos uma taxa de positividade de 9%, e resistência à rifampicina de 3%. Quando vem neste gráfico de confirmação bacteriológica, nós tivemos em 2023 46% apenas dos pacientes apresentavam confirmação bacteriológica. Ainda temos um número maior de casos que são tratados com diagnóstico clínico. Podemos dizer que, para o caso de aumento do número de testagem, nós tivemos alguns constrangimentos no passado, alguns relacionados com a funcionalidade dos equipamentos devido a dificuldades em fazer manutenção das máquinas, assim como a situação do Covid, que de certa forma fez com que o número de casos de amostras enviadas ficasse estacionária. Então, em 2020, finais de 2022 e início de 2023, nós já tínhamos um contrato de manutenção mais duradouro, foi feita a manutenção de maior parte das máquinas e isto resultou num aumento da testagem. Quando olhamos para a tendência da notificação de casos, vocês podem ver algumas províncias do norte do país a começarem a mostrar um cenário diferente em termos de aumento do número de casos. Isto aqui é devido ao comportamento da própria doença, mas também à instalação de novas máquinas em algumas dessas províncias. Esta aqui é a tendência da notificação de casos de tuberculose de todas as formas. Nós temos estado sim a aumentar o número de casos de tuberculose de todas as formas. Como podem ver, tivemos em 2023 cerca de 116 mil casos, comparado com a estimativa da OMS, estamos mais ou menos próximos. Importa só informar que estes 119 mil não é necessariamente a estimativa da OMS, como o relatório ainda não saiu, nós tivemos que pôr aqui um número só para garantir que o gráfico saísse, mas se olharem para 2023, nós já estávamos com uma cobertura de tratamento de 92%. Então, este gap entre o diagnosticado e a estimativa da OMS tem vindo a reduzir ao longo do tempo, à medida que a expansão dos serviços e melhoria também do referenciamento das amostras para os locais com testagem. Quando olhamos para a tuberculose resistente, multiresistente e resistência à rifampicina, o cenário não é muito bom. Nós podemos ver que existe um gap muito grande entre aquilo que é a estimativa da OMS, que temos aqui nesta linha acima em roxo. Então, esta é a estimativa da OMS e abaixo temos o que foi diagnosticado em vermelho e o que iniciou o tratamento em amarelo. Então, nós ainda continuamos a ter um gap grande entre aqueles que são diagnosticados, ou seja, aqueles que deviam ter sido diagnosticados e aqueles que são efetivamente diagnosticados. Como eu disse anteriormente, no slide da confirmação laboratorial, nós ainda temos uma confirmação laboratorial abaixo de 50%. Acreditamos que com o aumento desta confirmação laboratorial, nós também possamos duplicar o número de casos de tuberculose multiresistente que serão diagnosticados. Então, ainda existe muito trabalho que deve ser feito, embora tenhamos uma cobertura relativamente aceitável de equipamentos. O principal impacto que nós encontramos na implementação desta tecnologia é este. Como vocês podem ver, nós agora temos casos de tuberculose com resistência à isoniazida em quase todas as províncias do país. Províncias como Niassa, que é a primeira que encontram, eles podiam ter anualmente 1 a 2 casos, e com uma implementação de pouco mais de 5 meses, nós já temos 10 casos. Então, alarma um bocadinho, mas também ao mesmo tempo conforta, porque como não tinham este tipo de equipamentos lá disponíveis para o diagnóstico, por isso é que não encontrávamos. Mas esta é que é a situação do país neste momento. Como podem ver, temos aproximadamente 50 casos desde que começamos há pouco mais de 4 ou 5 meses. No nosso plano de implementação, começou em 2023 com a aquisição de equipamentos. Compramos em 2023, via fundos de fundo global, 36 máquinas. Temos planos de continuar essa aquisição até o fim da subvenção. Então, este ano não será comprada nenhuma, mas tem várias atividades que vão acontecendo. Então, como podem ver, temos as distribuições dos equipamentos, já fizemos a revisão, a atualização das guidelines, conforme mostrei nos algoritmos que partilhei antes. O primeiro grupo de profissionais de laboratório já foi treinado, é este que já está a operar com as máquinas, e esse exercício é contínuo à medida que formos recebido novos equipamentos. Em relação ao treino de clínicos, também é algo que vai ser de forma contínua. Acreditamos que à medida que o tempo vai passando, de acordo com aquilo que temos escutado em relação a estes equipamentos, vai haver uma substituição gradual dos módulos de 6 cores para módulos de 10 cores. Bom, isto não é algo que depende totalmente do país, depende também do próprio fabricante, porque, pelo que sabemos, vão descontinuando estes módulos ao longo do tempo. Temos alguns desafios, temos sim estes equipamentos instalados em alguns lugares, temos sérios problemas de energia em alguns sítios, com várias oscilações de corrente, que por vezes não permite que os testes sejam feitos. Temos problemas de acesso às unidades sanitárias, distâncias muito longas, e em alguns sítios que precisa ou de barco, ou que não tem uma boa não diria navegação, mas por causa do terreno, porque as estradas são muito estragadas, e quando temos épocas de chuva não permite que essas unidades sanitárias sejam visitadas. Então, tudo isto vai refletir naturalmente no sistema de referenciamento de amostras, sem contar que também com a instalação destas novas máquinas de 10 cores, nós tivemos que refazer o nosso fluxo de envio de amostras, passando a serem enviadas, por exemplo, daquelas máquinas que tenham que sejam máquinas para ultra, é preciso que novas amostras sejam enviadas para as máquinas de 10 cores. Em algum momento, este referenciamento não funciona como nós gostaríamos que funcionasse. Então, mas é algo que ainda estamos a estudar e a otimizar. Acreditamos que à medida que vamos assumindo e adotando estas tecnologias, vai melhorando. Estamos também ainda a desenvolver o sistema de reporte, temos dados ainda agregados de uma maneira um bocadinho, usando fichas Excel, porque nós também estávamos a fazer revisão dos nossos novos instrumentos de gestão de tuberculose, onde vai incluir todos estes dados. Então, os dados ainda não estão a fluir pelos novos instrumentos de monitoria e avaliação, que começaram a ser implementados, na verdade, há mais ou menos um mês. Então, nós ainda não temos toda a informação lá disponível. Então, em jeito de conclusão, e tudo isso que eu gostaria de apresentar para o caso de Moçambique. Obrigada.
Fantastic, Dr. Claudia from Mozambique. What an experience. And really, we're beginning to see the effect of deploying this very useful tool. And of course, what we've heard from Uganda and also from the Cepheid team. And fantastic work from also the delegates who are with us today. The questions that are coming through, very, very insightful questions. And we'll take not a lot of time, but get to those questions again. And again, also thank you to my team, the Cepheid team, the Makerere University team, and then the Mozambique team for already dealing with most of the questions in the chat. But just in case some people were listening in and not going through the chat, let me just run through a few questions. Before I do that, I also have to disclaim that we have industry partners that come in to support the sharing of critical information that guides policies and of course practices out there. This does not constitute an endorsement from the ASLM side. I just wanted to make that clear. And so the first question, I want to take it to Willie. And Willie, in your opinion, you've seen the results from your verification studies, but you also know that it takes a bit of time to develop the protocol, but also then run the study, get the results out, and then begin sharing it, disseminating. But it looks like because we're dealing with the agent, it's Mycobacterium that we're dealing with and the mutations therein. And so that is probably the behavior of the agent may not necessarily population dependent. And so for countries that may be looking at taking up the 10 color machines, would you encourage them to run, again, verification validation studies, or based on the fact that actually this is a WHO pre-qualified, and again, the Cepheid team will confirm this, and of course, the results that are already available out there, would they just go and implement instead of doing verification studies prior?
Very good question, Francis, and thank you for coming up with that question. Actually, it impacts most of the countries that I've visited for uptake and rollout. It takes time, and the WHO does not recommend that any endorsed test, the countries just take it up and roll out without doing any country validation. However, it is recommended that you can do roll out what we call implementation research or operations research. You learn as you implement. So given that countries with the similar, which you can say largely similar population, similar burden, similar diversities, they could do rollout and do operations research. They understand, they learn and adjust, and then implement, learn, adjust, and implement. The procedure that we went through might be somehow lengthy. For a WHO-endorsed test to take a year or two without uptake and rollout, it is quite a lot of time, given the where we are focusing to go in terms of ending TB. So I think operations research, implementing as you learn and adjust and move forward it might be, in my opinion, as the expert, not the WHO opinion, might be the best way to expedite uptake of these diagnostics.
Thank you. Thank you very much, Willie. And let me get to the next question. And it is coming in from Buthelezi. I'm trying to merge it up with one that came from Lauren and others. And this is going to the Cepheid team. Again, I know that some of the answers are already in the chat, but just for additional clarity. So the 10 color, kindly confirm, the 10 color is a machine, or the 10 color is actually the cartridge that is run on any machine that has the software that can run the 10 color. But if it is a different device that you use with, of course, a different cartridge, why don't we work on making the available devices, upgrading them so that they're all 10 color, and you just use whichever cartridge and then pick on the applicable software that runs whichever cartridge it is that you're using.
Okay, so the 10 color is really a different module that basically is included in the same GeneXpert system. So it's a module change more than it is, software or anything like that. So ultimately, a 10 color system, there's certain assays that need a 10 color module to be running this test. So XDR being one of the examples of that. And ultimately, with the evolution of the GeneXpert system and the tests that will be coming on board over time, the goal is to ultimately, grow into having and transition into 10 color modules across all systems eventually. And that's pretty much the plan. And that will, enable and cater for panel testing, and that does as the tests become available and evolve.
Thank you, Dipti. And that innovation, that ongoing innovation, really speaks also to the fact that even with new therapeutic agents that are coming on the market, you will also continue revising and making sure that you can cover as much that is playing in the space of TB care and treatment.
Yeah, I mean, I do understand, and I've answered quite a few questions around this in the chat, but really, I think, currently we are aware that there are new drugs that need to be considered. These will be considered in the evolution of the TB cartridges over time, but currently there's nothing that I can say specifically in terms of timelines or more details around that.
Thank you. And lastly, for now, for you, why isn't there color differentiation between the multiple cartridges that we have?
I think one needs to consider, I guess, this is a cost issue as well that one needs to consider. So over time, I mean, that's just something that we've not been able to do over time, over the many assays that are running in the system. But I just want to also add one more thing. There were some questions around the GeneXpert MTB Ultra assay and then the XDR assay. And
Yes.
Can the MTB Ultra assay be run on the 10 color? And that ultimately, as I say, is any test running on a 6 color can be forward compatible to a 10 color system. So enabling, and there's already been WHO equivalency studies done to show that equivalent performance has been achieved for running an MTB Ultra assay on the 10 color module as well. Thanks.
Thank you very much. And let me take this to Willie so that I give you some time to take a breather. And Willie, Miriam is asking, and she's speculating. She's not sure if you, in your performance assessment of the platform, if you did disaggregation by mycobacterial load. So in determining performance of this new tool, were you considering the mycobacterial load, whether from the primary sample or from your culture isolates, to just be sure it's performing as well, or that was not a consideration in your study?
That was not a consideration in our study, but I think DIPT can clarify on this. Expert XDR just expands the principle of the expert ultra, and the principle of diagnosis is maintained. Like now, if you have low bacillary load, you can have some chances of having false results, and therefore, even in the it has confirmed that it is not recommended to run on the lower bacillary load samples, because there you will have some area of doubt. However, every study, every diagnostic, you have to validate it in line with the purpose it intends to achieve. So this test is intended to achieve susceptibility testing, but not mainly primary diagnosis of TB. The primary diagnosis of TB is reserved for expert ultra cartridge. I guess I've answered it, but DIPT can supplement on that.
DIPT, your addition to that, if any, and then I'll hand it over to Claudia as well. If you have, I know you've not gone into the verification studies, but if you have any comment related, but DIPT, if you have any additional comment related to that.
Yeah, I think in terms of the bacillary load, I mean, if there's a trace result from ultra, that that's not a sample that's recommended to be reflexed. Of course, it's too low a load to be able to enable any drug-resistant melt analysis or anything to be done. Basically, what we know, just to explain also the difference between the MTB Ultra and the XDR cartridge, the principle is pretty much the same. It's about using melt analysis to detect drug resistance, both in the Ultra assay as well as the XDR assay. So, if there's insufficient bacteria to be able to amplify and do a melt analysis on that to determine drug resistance, that is unable to happen, unfortunately.
Thank you. Let me get it to Claudia a bit. And Claudia, the question I'm putting to you is, you and the Mozambique team seem to have taken the implementation approach, learning as you implement, because I think I didn't hear, and I might have missed that, and my apologies if I did. I might have missed the fact that you did not do a comprehensive verification validation study. And so as you do your implementation, are you accruing data that then you will retrospectively analyze to just keep you at peace that the tool you're using is actually a tool that gives you what you want?
Não sei se percebi muito bem a questão, mas sim, Moçambique fez uma verificação. Eu não trouxe aqui os dados desta verificação, mas não são muito diferentes do que o Uganda apresentou. A proporção, quando comparado entre o teste de sensibilidade convencional, não era tão diferente assim. Na verdade, nós fizemos a verificação porque é norma de laboratório fazer, porque os testes já são recomendados pela OMS e faz parte da nossa norma pelo Instituto Nacional de Saúde. Sempre que entra uma nova tecnologia, é necessário fazer a verificação. Então, esta verificação foi feita, sim. Talvez no futuro poderemos partilhar os dados apresentados, mas não tem muita diferença quando olhado para os testes convencionais.
Thank you very much, Claudia. And finally, Willie, I think we're getting to the top of the hour. And Willie, from your side, I know that your conclusion was that this is a good tool and it should be put out there for large-scale implementation. Did you have a working cutoff if it had worked below a certain cutoff? So did you have a working cutoff that if the sensitivity is below this, specificity is below this, positive predictive value, negative predictive value? And if yes, what was the basis of choosing some of those cutoffs?
Yeah, definitely. In the validation study, we were compared with the literature, what is acceptable with the literature and in line with the WHO, and that's what we based on. But basically, it was not a non-inferiority or superiority study design. It was a design that was giving acceptable performance. So we achieved the acceptable performance for rollout in line with the challenges and limitations we had in our study. And we do recommend that the implementation research should keep on. We keep on learning and understanding this diagnostic, but at least we got the minimum required cutoff. Thank you.
Thank you. Thank you very much. So, guys, we've reached the top of the hour and we've exceeded by a minute or two. Our apologies for going overboard today, but just closing remarks, and I will start with Claudia. What are your closing remarks in about 30 seconds?
Muito obrigada pela oportunidade. Bom, o que eu posso dizer é que é algo que vai nos ajudar muito a melhorar o diagnóstico atempado dos casos, porque, como eu dizia antes, nós somos um país muito largo, um país com muitas unidades sanitárias, mas poucos laboratórios. Eu não pus aí o rácio entre as unidades sanitárias com laboratório, com expert e com sobre o número total. Então, só para terem ideia, nós temos 1.800 e tal unidades sanitárias em todo o país e só 300 e tal laboratórios com microscopia e alguns com expert. Então, ter este acesso a este tipo de tecnologias quase point of care é bom para nós porque por causa do sistema de referenciamento e tudo mais, precisamos mesmo de ter equipamentos como este. Uma das coisas que eu acho que a Cepheid deve começar a pensar, já disseram aqui que estão a pensar em pôr novas drogas, acho que deveriam acelerar sim a inclusão de bedaquilina, inclusão de linezolida, inclusão de pretomanida, que são fármacos que estão nos novos regimes de tratamento em todo o mundo. Não vai fazer sentido nós termos que continuar a enviar para os laboratórios de referência. Pela nossa experiência, o que está a acontecer é que há tecnologias, por exemplo, que vão entrar em desuso nos laboratórios, vamos precisar de continuar a fazer culturas, naturalmente, para seguimento. Então, uma coisa é seguimento, outra coisa é o diagnóstico atempado. Então, ter estas tecnologias mais próximas do doente, com o melhor que é possível. Eu acho que é uma mais-valia, que é importante dar seguimento mesmo. Não sei quando é que a Cepheid está a pensar em colocar isto no mercado, mas eu acho que é algo urgente, porque, por exemplo, em relação à pretomanida, nós só podemos testar a nível dos laboratórios de referência. Então, isto é importante para um país como Moçambique, que é um dos que tem alta carga de tuberculose resistente em África. Então, é isso que eu gostaria de falar por agora. Obrigada.
Thank you very much, Claudia. Let me get it to Willie, your closing remarks. And in 30 seconds, Willie.
I must say thank you, Cepheid, for coming up with this innovation. Being in TB diagnostic arena for 17 years now, I can tell you that you have done a tremendous, a very important aspect coming up with this test. There is no perfect test, but at least the attributes outweighs the remaining limitation. We only request that you listen to the users, you listen to the countries' demands. I know the challenges of adding more drugs, but we'll keep on working together from the scientific side to see that we find those targets and those targets that can be incorporated within the cartridge. But at least for now, I think countries have an alternative, rapid and accessible and easy to use molecular diagnostics tool. I know all of the others on the line. I don't have to talk about them, but I'm happy with the performance of the GeneXpert XDR cartridge. Thank you.
Thank you. Thank you very much, Dr. Willis Ngoba. And finally, Dipti, and if anyone from your team may also want to talk about the cost implication of the 10 color.
Okay, so let me give just a 2-minute basic summary of today. And I think, you know, my title said it all really, is that, you know, we all need to work together to close the gap, and we all need to work together to make significant strides in diagnosis as well as drug treatment initiation. So I think with the tools we currently have, we need to make the best of that. And I'm going to leave it to anybody else in my team to take the price question, as I'm not sure if there's any commercial people on the team.
I know only Rumbi may have rights to unmute, but if we do not have anyone to deal with that, no worries at all. We can, of course, always get back to you and get some specific information related to cost implications. And colleagues, thank you again so much for joining and being part of this very informative session. I hope that you've got that traction in you that can then move you to the next level. Remember, we cannot continue using tools of 15 years ago to deal with the very ever-changing environment in the diagnostic space. We have to keep innovating, because even the agents that we're running after are actually running away from us. So with those, I must say thank you very much, and keep on the lookout for our next advert for the next session that will be coming anytime soon. We know that we've had some little bit of a backlog with the materials being made available to you. I know there are questions related to that, but be sure all the materials, including the forms that Dipti and team are speaking to, will be added to our resource center so that you can access them just by clicking some of the links that will be shared in those library spaces that we have online. So until we meet again from us, ASLM, do have the rest of your day, afternoon, or evening, depending on where you're joining us from. Thank you.